Hello, and welcome to the show Beyond the Journal, where we discuss social media, digital education, and current controversies in cancer and medicine. I'm Dr. Jack West, Associate Clinical Professor in Medical Oncology at the City of Hope Cancer Center in the Los Angeles area. And I'm joined today, as always, by my co-host, Dr. Charu Aggarwal, who is the Leslie M. Heisler Associate Professor of Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center in Philadelphia. Hey, Charu.
Hi, Jack. Today, it's our pleasure to invite to the show Dr. Stephen Vogl, who actually doesn't need an introduction. Welcome, Dr. Vogl.
Thank you.
So I'd like to start off by really acknowledging that you're famous, and you're famous for being Vogl, New York. I mean, you've had an article named after you. You have a huge fan following, and you've always been the voice at microphone 1 or 2 or 3, but you've always been the voice at the microphone and have often challenged and critiqued the prevailing mindset in the room at national meetings. And, a lot of people have related with your questioning. But tell us how it started and what was your motivation to begin challenging, the conventional prevailing mindset in the room.
So it's really not about the mindset in the room. It's generally after there's been an oral presentation, and usually I'm not prepared. Usually I haven't studied anything before. I listen to what was presented, and if what's presented is well done and well analyzed, and the conclusions are justified by the data, and the statistics are right, I don't go to the microphone. Unless it's someone I really like and I say, boy, nice presentation, thank you. But I can't recall ever doing that without asking a question too. So when do I ask a question? Sometimes I ask a question because I don't know the answer. And occasionally that's revelatory. I remember I listened to a paper, it was a breast cancer paper, about PI3 kinase inhibition and about looking for PI3 kinase mutations. So I don't know if you can see my fingers. I know about this much about PI3 kinase mutations. So I got up and I asked a question that came to my mind, and I thought most of the room probably knew the answer. But if I didn't know the answer, then probably there were some other people in the room that didn't know the answer. And I said, so you've been talking about patients with PI3 kinase mutations, without PI3 kinase mutations. Are these mutations you're talking about all activating mutations? And all of a sudden poured out, well, we did serum circulating DNA, and we knew which of those were activating mutations, but we did it on the tumor. We actually don't know. Wow. The data just got thrown out. Now, that was just an honest question. I didn't know the answer. I assumed I was stupid and that everyone else in the room knew which mutations he was talking about. So there was no dogma here. There was just something left out of the presentation. So sometimes I see a presenter doing an analysis that wasn't his primary endpoint, that wasn't justified in the statistical considerations. And he's telling us this is gospel. It's not gospel. It's hypothesis generating. It's a very nice observation, perhaps. And usually that observation is made because it'll sell some drug and make some company rich. So that's not dogma.
Right.
That's just speaking to the quality of the data and the justification and honesty of the analysis.
I mean, I would say it seems that you resonate with a lot of people because it's kind of plain spoken, homespun truth that sometimes somebody has to say the emperor has no clothes, or at least ask that question. One of the things we hear in our training, in our lives, is there's not a bad question, because chances are, if you're wondering it, other people are too. And I would submit that you may represent kind of a lot of general oncologists, a lot of people who aren't extreme experts in a narrow field. And so I think there's a real value in having an outside view that doesn't presume what some people who eat, sleep, live, and breathe this narrow topic have come to accept. So am I overstating it, or do you see yourself as maybe being that role?
In past years, I was a little bit more shy and a little less confident. Really? So I used to lean to my left and say, do you know what that means? And then lean to my right. Do you know what that means? And I figured if 3 out of 3 didn't know what it meant, there are probably a lot of other people who don't know what it meant. Now I don't bother doing that. The meetings have become more international. Half the people next to me don't speak English. So when I have a question, I just ask if I think it's a good question. If I think it's a bad question, I don't ask it.
But do you feel at all like you may represent a broader population of a lot of general oncologists today, or are you just considering yourself representing yourself?
So I think it's best to say that I consider myself representing the patients who aren't in the room and are going to be subjected to the conclusions of their doctors who are in the room. So the questions are my questions. I haven't cleared them with anybody. I don't wonder whether they will like them. I would prefer that they not be embarrassing to me. But I'm worried about some guy who's snoozing, wakes up for the conclusion, and goes home and believes some story told by a drug company or its representatives that is misleading or downright unjustified.
Do you feel, you have been in oncology for a while. I've been in 2 decades.
46 years.
God bless you. And fortunately, it's changed a lot over that time, and especially in the last couple of decades, many ways far better, but some of the changes have been the evolution of some of the endpoints so that overall survival is not as uniformly the endpoint in phase 3 trials. Increasingly, it's PathCR or progression-free survival. We've also seen that a couple of decades ago, a lot of trials were not sponsored by industry, and now industry sponsors almost every randomized phase 3 trial. So from your perspective of having done this as long as you have, do you have a lot of concerns about this, or is this overall far more good than not?
So overall is hard for me.
Okay.
So we have 2 classes of patients, those who are well and those who are sick, and they're different. Let's start with the easy ones, those who are sick. We want to make them better. Now, it'd be very nice if we can cure them. Most of the cancers we treat, that's not the case. Certainly lung cancer docs don't cure anybody with metastatic disease that's symptomatic, or very few, let's put it that way. So you want to know if you make them better. And making them better is a very high quality endpoint. If you relieve symptoms, improve quality of life, improve energy, even for 3 months, that's worth it. So that's fine. And if that's hard to measure. Above ground or below ground is very easy to measure. So there's much less worry about the quality of the data, about the ascertainment of the endpoint, if it's an endpoint which is incontrovertible. Yeah. I don't know about you, but I see very few resurrections in my practice. So when someone's dead, they're dead.
Yeah.
Living is better than dying,
but
living and being miserable isn't. So I think if you have fifth-line chemotherapy for metastatic breast cancer, and it prolongs some poor woman's misery for 2 more miserable months, I think that's a terrible endpoint. If you have somebody who's miserable and you make her asymptomatic for 2 months, I'll do it. But they never give us those data in fifth-line metastatic breast cancer.
Right.
Costs too much to get the data.
Yeah.
So I want to go back to our meetings and how data has changed and how data delivery has changed. We've, as you were mentioning, you've been in this practice, been in this profession now for 46 years, and we've really witnessed a sea change, right? Every meeting, there's a practice changing or potentially practice changing trial that hits center stage. And shortly thereafter, I think the FDA has really partnered well, and there have been several FDA approvals that have come through. Usually pre-COVID, everyone would be in the same room. And, sometimes I would hear, oh, Vogl, New York asked such a good question. You should have been in that room. And, you sort of feel like, oh, I missed out on something. There was always this fear of missing out. However, the pandemic has changed something for all of us. We're not consuming information or new trial data. How do you keep up, and how do you keep up with making sure that you're still analyzing the data in the same way that you did pre-pandemic?
So actually, the pandemic has made it easier for me because I have patient responsibility several days a week. Most of the days, my travel was limited. So basically, I would go to 2 meetings out of town a year. And otherwise, I would stay in town. And if a dog and pony show came to perform for a day or 2 in New York, I would pay my money and attend and be on call all the time. Now that everything is virtual, I went to the last ESMO meeting. Now, nobody knew I was at the last ESMO meeting but me, as I asked questions, but no one noticed them, and no one heard them, and no one heard the answers. Mostly they didn't get answered. So it's something similar to a plenary session at ASCO. So if you had some eggs at ASCO, you could have fried some on my forehead during some of the plenary sessions. I was so angry. This year, virtual, or other years not, because I couldn't say anything. Some of you may remember the first positive checkpoint inhibitor trial. It was a trial of ipilimumab, sometimes I can say that, against some vaccine. And I was sitting there with 25,000 people in 2 different auditoriums, fuming. What control group is this? We don't know if this drug, Ipi, was better than the vaccine, or the vaccine was just worse than control. No idea. And I was just fuming. I wrote an editorial. Nobody read it. Turned out it was a good drug. That was fine. But so that hasn't changed. It's just become more frequent that I get frustrated. So I have to seek other ways of making my opinions known. Well, it's very convenient to have 5,000 people in a room hear what you have to say, especially if it plants a seed of doubt that the analysis and the conclusions are valid. So that's gone, basically.
So let's talk about some of those mechanisms, because you do have a column and some forms of output. A lot of this information, these exchanges are now happening online. How do you get most of your information these days? Are you reading print journals anymore, or are you accessing it online? I know you're on some social media, but I don't know if you've really cottoned to it that much. So kind of how do you access the information? And do you think that some of these summary digests that come in our emails are too much PR spin and not enough data?
So let's go slowly. It's difficult to keep up. Very, very difficult. because the state of the art now is that you can't be at all the presentations, even if they're virtual.
Yeah.
They're all over the world in all sorts of time zones. And some of the things presented, certainly in Europe and in Asia, are very important. And they don't get printed for God knows how long. So sometimes we're stuck. And I can't read all the print journals, even if I had 40 hours a week to read them, because there are too many. It used to be there was one journal, Cancer. And there were a couple of other ones, but they very rarely had anything important. Then it was Cancer and JCO. And now there are 6, 7 oncology journals with good stuff in them. And maybe you can read 7 journals a week. I can't. So a lot of the reading I do is when I have a particular problem, I look it up. And looking at the computer age makes it much better. I want you to visualize. I was the medical oncology in charge of taking care of gynecologic oncology in a university medical center. And, there are a lot of funny little diagnoses in GYN oncology. And the gynecologic oncologists would send me one. So I would look at the patient, come back next week. I would take a half a day, go across the street to the library, spend 2 hours with Index Medicus, 2 hours in the stacks, and 1 hour Xeroxing. Take it home, read, and then I knew what to do.
And it's not like that anymore?
No, it's wonderful. You go online, in about 5 minutes, you have the references. And so I have friends. Hopefully at the end of this session, you two will be my friends. And when I have a situation, eventually I think I'm smart enough to frame the question. And I call a friend and I say, does this sound reasonable? I don't call. I usually send an email.
Yeah.
And so asking a lot of questions at meetings that are good questions produces friends. So they get flattered when I ask, which makes it very nice.
Excellent.
Did I answer all your questions?
I guess one of the follow-up questions on this is, how do you actually keep up then? Are you only doing it on the basis of looking up cases, or how are you informed about a new practice or practice-changing paradigm? And second part of this question is, what advice do you give to a young person who's graduating fellowship, who really wants to be a true generalist? What would you tell that person? How do you keep up with doing breast cancer and myeloma and lung cancer and GI cancer?
So you don't necessarily, you don't have to know everything. You just have to know where to look.
Yeah.
And it helps to know people who not only do only that disease, so they go to every meeting, but also who know the quality of the people doing the presentation and doing the studies. There are some people I would never believe. If they told me the sun came up in the morning, I wouldn't believe them. And there are some people you just can't trust at all. And then there are people who, if they say it's dark outside, son of a gun, it's dark outside. That doesn't mean they're always right, but at least they're not trying to lie to you. One of the big problems with meetings is that a large proportion of the presentations are written by drug companies, and they hire a presenter to give it for them.
In fact, that's another thing that we're starting to see more of, is that if you look at if you analyze the patterns over time, medical writers are involved far more than they used to be. So, yeah.
So the medical writers are benign.
Yeah.
What's a little less benign is when the interests of the drug company direct the analysis and the conclusions. Who prepares the slides and edits the words isn't as important as whether it's the content.
Yeah. Yeah.
So when I read a paper and I see a medical writer, then I know what that paper is for. And I pay no attention to the conclusions at all.
Now, obviously, you're practicing in New York, which has really, over the last year, been hard hit by the pandemic. What has it been like for you? Did things shut down a year ago? Did you switch to telemedicine? And if so, how was that? And what are things like for you now, a year later, where it's still an ongoing concern, but it's not the threat it was in April of 2020?
I don't know how long you want me to talk about this, but the first thing that happened was I got COVID. In the middle of March a year ago, almost exactly to this day. I actually was tested when I was asymptomatic for some peculiar reasons. And a day and a half later, I got awakened in the middle of the night. Dr. Vogl, your patient, Dr. Vogl, has COVID. So I was out for 2 weeks. We had patients who needed their chemotherapy. Happily, my nurse wasn't out. And I kind of did telemedicine on FaceTime.
Okay.
She would show me the patient in the office, and I would say, okay, give her chemotherapy. She would show me the counts, and we would discuss the labs. I thought I could try and work, but I was too sick. I could barely get out of bed. Then I had a problem. I had to convince my office staff that I wasn't going to infect them. I met the New York City, the New York State, and the CDC criteria for not being infectious at the time, which were not based on testing because there wasn't enough testing around. Eventually, I had to get tested to convince them I wasn't infectious, and then they let me alone. They got calmer later, but they were very frightened. Otherwise, we just stretched out the office hours. So we had fewer people in the office at one time, fewer people being treated at one time. And we tried very hard not to let anyone sick in the office, sick with a febrile illness.
Yeah.
In terms of the actual risk, while there was a lot of COVID last March and April in New York City, there's still plenty now. It isn't very different. There are a lot of people with COVID now in New York City. It's just everyone was more frightened then, and people have sort of gotten more used to it now. So we still run office hours. I don't do much telemedicine. I don't have an administrator who tells me it's more efficient. And I'm the kind of doctor who thinks the most important things are the things the patient may not be telling me. And I sit in the room and let the patient talk and look.
Yep.
But that's an old-fashioned doctor. I actually look at the patient, and I don't have a computer in the room with the patient.
Okay.
I've tried that. It's a total failure.
You mentioned you use FaceTime. I have to say, I have to admit, and you probably know this from hearing about experiences from your son, who's actually my colleague, that, at Penn, we've probably had an easier time at telemedicine because some of these IT technologies have been, sort of put in place for us. But do you, when you were starting telemedicine, you said you used FaceTime, but during the course of the year, were there IT technology advances that were placed into your practice that you could use on an ongoing basis, or you pretty much used whatever was available and easiest to use? So
you used the passive voice technologies that were placed into your practice. There is no were placed. If I don't place them, they're not there. So I didn't place them. I don't know about them. And I'm not particularly comfortable with them. So I'm in a different position probably than you are. Are you the only doctor taking care of your patients? I am, pretty much. I have friends and colleagues who send me their patients. And if those patients have metastatic lung cancer, pretty much completely I'm their doctor because I see them much more often than does their primary.
Yep.
Same thing goes for myeloma patients. Some of the indolent lymphomas, they can go anywhere they want. They're fine. But sick patients, diffuse large B-cell lymphomas, I'm their doctor. And some of the patients I've been caring for decades, I know them. And some of them, if they have a complaint, I worry because they've never complained before. Some of them, if they don't complain, I worry they must be desperately sick because they've never had a day without a complaint. So if they have one now, it's because they're so sick they can't talk.
Yeah, that does happen. Now, we've alluded in passing to some evolving endpoints, patterns that a lot of trials now are using progression-free survival or path CR rates as a primary endpoint. And frankly, Charu and I, as lung cancer folks, are a little later to this than say in breast cancer, where you treat far more than we would, which would be almost never. But in breast cancer, progression-free survival, relapse-free survival, pathologic CR rates leading to broad use of neoadjuvant, that's kind of become de rigueur. What's your perspective? Have you kind of acclimated to this? Do you think it is appropriate in some, many, or very few to no settings right now to use surrogate endpoints instead of overall survival?
So we sort of hinted at this before.
Yeah.
I think there are two groups again. So people who are sick, if you make them better, that's good. People who are well, all right, they have a tumor in the breast. You're going to take that out and they'll be without evident cancer. All right. So there, basically, you either have to make them live better or make them live longer. And really better, since you're talking about sometimes periods of time of years to a decade before they'll relapse, right? You're trying to prevent a relapse in 5 years, 10 years with your interventions. If you make 5 of those years miserable, that's a big target in terms of quality of life. You give tamoxifen, you make hot flashes. You give an aromatase inhibitor, you make joint pain. So unless you're having a big impact on overall survival, quality of life is down the tubes. So the answer is for adjuvant therapy. Adjuvant therapy now, overall survival is really the endpoint. Now, there's a hooker there. If you're at the very top of the survival curve, all right? And the good example this year is a relatively small HER2-positive breast cancer with negative nodes. The cure rate, all right, let me say it this way. About 1% of the patients will develop distant metastases at 7 years. Maybe it's 2%. Depends on which study you read, done at the same center. But hardly anybody relapses with a lethal relapse. They're still going to be sick with something. They're still going to die of something, but not of the cancer that you're treating. So if you want to study that, they have more deaths in that study. It's called APT, from car accidents and strokes than they do from breast cancer. So you can no longer look at overall survival as an endpoint when the prognosis is very good, because you'll be looking at the wrong thing. It's not what you're trying to measure. But so that's fine for the doctor who's interested in what treatment to give. For the patient, you still have to show that their overall survival at least is not compromised.
Yeah.
Because I can think of therapies where you treat the cancer great, but you still kill a few people. And especially at the top of the survival curve, when you've made the prognosis very good, you have to be very careful not to harm the patient. There's an example of this that just came up in San Antonio 3 months ago. There are women with 1 to 3 positive nodes with estrogen receptor positive breast cancers who have a low recurrence score, less than 25, who are postmenopausal, do great. 2.6% metastases at 5 years. So that's way up there.
Yeah.
And you got to be very careful not to do those people harm. Don't get aggressive for a 0.3% improvement in metastasis-free survival, because most of the people you're treating don't need that treatment.
Right.
Did that answer your question?
Yeah, it did.
Can you talk a little bit about, in relationship to harm and no harm and really critically analyzing the data, especially as it relates to adjuvant therapy? Can you also talk a little bit about how we as oncologists should factor in drug pricing, overall responsibility, and perhaps, overall responsibility to the society at large? What are your thoughts about that?
So let's start from, I have many, many thoughts, and you're not going to get to all of them in an hour. So first of all, what's the doctor's responsibility? And I think the doctor's responsibility is to the patient. They trust us, and they're really vulnerable, and they have only us to protect them. Oh, they have social workers, they have advocates, they have lawyers, but, they really only have us to tell them this is what you need. We have, and to formulate the decisions they have to make. They don't know how to formulate those decisions. So I think the patients are first. As far as the money goes, the society has proven also to be defenseless. In the United States, we have the best government money can buy. The drug companies, to some extent, the hospitals, the medical groups, the very large ones, and the insurance companies, they've all bought it. And all of them are making a lot of money. Now, then they tell the doctors, save us some money. But that money is going to go into the pockets of all those systems that really aren't serving the patient. They're serving either a stockholder for a drug company, or an insurance company, or the glory of and bonus of the CEO of a big medical system or a hospital. I think the country needs to take back control of what used to be charitable institutions. Most of the hospitals still get tax breaks.
Yeah.
But they're being run to make money for somebody, not for the doctors and certainly not for the patients.
But at the end of the day, it seems that your view is that though it is a challenge, it's a frustration that costs are borne by all of society. At the end of the day, the physician's role is primarily, if not exclusively, to the patient and not to be a shepherd to resources for society.
So it's not so it's in the United States. This is not society. Society, I guess, to some extent, Medicare represents society, but United Healthcare or Cigna or Aetna, that's not society. That's a profit-making insurance company, and the modus operandi of an insurance company now, at least this year, is collect the premiums, invest them to make money, and try and pay out as little as possible. It used to be in the United States that the Blue Cross Blue Shield, were mutual insurance companies. They were owned by the insured. And their goal was to spread the risk, right? You pay your insurance now. When you get sick, we'll pay. But that's all gone. Those are all turned into for-profit companies whose goal, the ethical principle of a for-profit company, right? What's the ethics? Is General Motors' job to make good cars? No. General Motors' job is to make money for the stockholders. All right? So, and United Healthcare's job is to make money for the stockholders. That capitalism like this started in Holland, and that's how it runs. So the way to make, we don't have to necessarily throw out capitalism, but you need someone acting on behalf of society to make sure that in making their profits, they're still doing a job for the people.
Yep.
And I don't think our government, our societies have done that adequately. And certainly we need somebody to negotiate on the prices. Nobody seems to talk very much about it, but the pricing of pharmaceuticals depends entirely on a grant that society gives the pharmaceutical company. That grant is called a patent. if American laws didn't grant a patent, all the drugs would be dirt cheap because there'd instantly be a generic and they'd undercut the price. And if the first 2 generics didn't undercut the price, there'd be 3 more the next week, unless they were colluding in restraint of trade, which seems to be happening for generic drugs in the United States.
So you were right. You just didn't have one thought. You have many thoughts, and maybe we should have another episode on this question. But I'd like to just turn to a more fun aspect of what we do. Is we noticed that you've joined social media and you're on Twitter now. How's it working for you, and how do you find the platform? Have you engaged much, or are you more of a listener and observer? Tell us. So
neither. A friend of mine convinced me I should join Twitter. It wasn't clear to me why he thought it was a good idea. And it's still not clear to me why he thought it was a good idea. There are some people I know better and like better because of their Twitter posts. I don't know how to influence people on Twitter. I'm fundamentally uncomfortable in 144 characters.
Well, you now get twice that many, so you're...
No, I don't know. It seems to hit very soon. I suddenly see this orange or salmon-colored band at the end. And I suddenly have to take out words.
You can keep going till it says -1.
Yeah, but that doesn't take me very long. It's very hard for me to say. I can say little things, and that's all I've used Twitter for. But I don't know if I will ever use it very much because it's not amenable to careful, thoughtful analysis and considerations of weight and quality. It's.
Have you used it at all, that or any other social media, to keep up with just things like alerts about press releases, a link to a trial? I mean, I think there's ways to do it to both express thoughts, which admittedly is hard to do in that format, or unless you link several together. But it can be used. Certainly, I think a lot of people do, for just keeping up with the ongoing current of what's happening. But I don't know if that you've sampled that.
So I haven't used it for that. Maybe I should. Usually I get information from people who cite it to me, and then I go look it up if I can. And sometimes they'll refer it to me. When I can, I go to meetings and I listen.
So speaking of that, as we are entering a tail end of the pandemic, I don't think it's going to be over anytime soon, probably many months to a year or more. And I don't know that we will ever go back to 2019 patterns. What would you be inclined to do in terms of meetings? Are you looking toward ASCO as it was in the past, or do you foresee things are never going to be the same again? Are there things that you would keep about virtual meetings? Because obviously getting on a plane to ESMO is not as feasible as joining virtual ESMO, but at the same time, most of us found that the virtual version ain't nothing like the real thing.
So for me, the virtual ESMO was wonderful. I'd been to 2 ESMO meetings, and I was lost at both of them. So I managed to get to hear a few things and go to some art museums. One was in Nice and one was in Milan. Otherwise, I hadn't been to ESMO in more than a decade. So for ASCO, I still treasure ASCO when it was the only meeting. Before 2000, that was pretty much the only meeting I went to. Yeah. And I was the guy in the corridor running half a mile from one session to another in the middle of the hour, because there was a gastric cancer paper I wanted to hear in one spot, a lung cancer paper in another, a breast paper in another, and there was something good about Hodgkin's disease.
Yeah.
And I really like that. It's a little tiring. I don't move as fast as I used to. But so if there's an ASCO for 4 days, I'll go, and I always come early and stay till the last minute.
Yeah, I don't think I'll miss hoofing it to D2 anytime soon. I think that's run down to the Ari Crown Theater. And so sitting in a room with 25,000 people, that's always struck me as kind of a waste of time because they don't allow any questions. You take no part in anything. The chairs are uncomfortable. You're sitting with your elbows crossed in front of you. And certainly that kind of session you can listen to online with the same thing. The nature of meetings now, because there are so many and they're all over the world, is that we're not all sitting in the room anymore, Charu. And if we're in the room, we don't get to take part in the meeting. So I went to a World Lung meeting a couple of years ago, and they basically had no questions. At the time, I had a press credential, and I had to fight to ask a question as a press member. And it was a good question. I asked the presenter of the Nelson trial if there was an overall survival advantage to screening. And he said, yes, there was, but the trial was too small, so it wasn't significant statistically. But that's a very important question. Yeah.
Yeah. Definitely.
But that was as a press. And the chairperson of that session was very angry at me because she thought I was a doctor asking a question, not a columnist.
Excellent.
I don't know about you. I would be ready to go back to a meeting, as soon as we think that it's safe to. I do miss, meeting with colleagues and friends, and the hallway conversations is just something you can't replicate. I think there's pros and cons of everything. And
so the answer is I like the meetings. I made a lot of friends at meetings.
Yes.
And I remember things better when I'm in the room. And I especially remember things better if I'm afraid I'm asking a stupid question.
There are no stupid questions, right?
Oh, yes, there are. Every once in a while, you miss something on the slide.
Yeah.
And you're asking a question that's not only irrelevant, the basis of the question is wrong because you didn't understand what they did.
Touche.
So I sit there in the meetings with a camera, copying the slides. And before I ask the question, I'm standing at the microphone, looking at the screen on the back of my little digital camera to make sure that the basis of the question is correct.
Very good.
Tricks of the trade from Vogl, New York. This has been...
Everybody who sits in the front of the meeting knows me and my camera.
Yeah.
This has been so much fun. Thank you so much for taking time out to talk to us today. You can find us on iTunes or wherever you find your podcast content. We hope that you will subscribe and send us comments and feedback to beyondthejournalshow@gmail.com. We would like to thank Mark Lindsay and Talking Speaker for production and distribution support. See you in a couple of weeks with our next guest.
Thanks.
Thank you very much.
Thanks so much, Steve. This was fun.